Staphylococcus aureus is part of the normal microflora of the human body. It is typically found on the skin of approximately 1/3 of all humans. Clinical issues stem from staph penetrating the skin barrier. In these cases, it often presents as bite marks or inflammation of follicles and boils. These penetrations can induce abscesses, which require aspiration and drainage. More serious complications of Staph aureus include joint infections, endocarditis, or the most dangerous necrotizing pneumonia or fasciitis. This last conditions require immediate hospitalization and intensive antibiotics, and are often severe surgical debridement in order to avoid a systemic septic event. In 2002, 90,000 deaths due to bacterial infection were recorded in the U.S. Half of these were induced by resistant bacteria. In 2007, 100,000 cases of Mrsa were reported to the CDC. Of these, 19,000 patients died. In a 10-year study from 1997 to 2007 in Seattle, Washington hospitals noted a 23-fold increase in Mrsa admissions. This problem is not just limited to the populous or border states, as Mrsa infection rates have exceeded over 50% in some interior states. Across the pond in the UK, ran another 10-year study from 1996 to 2006 and found a 9-fold increase in Mrsa penetrance. Mrsa in Europe is more common in England and the Latin countries, while the Nordic countries have shown a much lower rate. An example is a research study in the Netherlands which tested Mrsa rates among pig farmers and their stock. The farmers displayed a 20% positive rate for Mrsa, while the pigs showed a 39% positive rate. These rates are believed to be due to the overuse of tetracycline among the pig farmers. The history of antibiotics is a sorry affair. It's repeats of a cycle of antibiotic introduction, followed by a couple of years of effective service, and then resistance begins. Penicillin was introduced in 1942, and resistance developed in 1945. Streptomycin was introduced in 1947, resistance developed that same year. In 1959, methicillin was introduced, and by 1961, Staph aureus had developed a resistance. This pattern continued until 1996, when partial vancomycin-resistant Mrsa developed. Upon its escape to the community in 1999, Mrsa infections began to spread, and in 2002, full vancomycin-resistant Mrsa arrived. Research into antibiotics has slowed down due to the speed of resistance and to the short term of use, making research less profitable for the drug companies. Due to this less profitability, only 5 of the 15 companies performing research in the early 1980s still do. These are GlaxoSmithKline, Novartis, AstraZeneca, Merck, and Pfizer. Once touted as our best hope, bacterial genomics has proven a dismal failure. Of 650 genomes decoded, only 5 genes have emerged as possible candidates for use. All of these only minimize gene activity and do not eliminate it. In the U.S., the CDC can only recommend actions. However, the states have begun to regulate more Mrsa screening and reporting. 17 states currently have legislation in place to deal with Mrsa. Many of these are states with the highest penetrance of Mrsa in their populations. Hospitals follow CDC and OSHA recommendations, which call for minimal isolation in a normal pressure room and require gown, glove, and mask protection for staff. However, this often is not followed by family or visitors. The Netherlands, however, have a far stricter approach. They require mandatory admission screening and full isolation reminiscent of TB, including a full negative pressure isolation and visitor restrictions. Our proposed program, based on the SACCAR recommendation presented to the British Parliament, SACCAR, the Special Advisory Committee on Antimicrobial Resistance, sets up a 7-step, 2-front program. It's following standard operating procedures. Mrsa patients' isolation is mandatory. Attached to this is hand washing and decon protocols, as well as a strict adherence to barrier precautions. Avoiding excess antimicrobial use and limiting patient and family mobility must be practiced. Finally, SACCAR recommends Mrsa screening for all admissions. Our program includes the above and introduces a community education element. Mrsa education is to be installed in schools following the first introduction to biology, usually in the 8th grade. Proper protocols will also need to be emphasized by physicians during office visits and upon admissions to hospital for Mrsa. This education must be applied to the families as well as the patients. Finally, in Scandinavia has been able to minimize their cases of Mrsa to less than 5% of all their S. aureus cases, and the Netherlands has even decreased this further to less than 2%. In the United States, the use of triclosan has proven valuable in combating Staph aureus. However, research has shown Staph epidermis has begun to develop resistance. When introduced as a pathogen into the system, Staph epidermis causes similar problems to Staph aureus. In short, the consequences of this program include a decrease in Mrsa infection and mortality, less reliance upon antibiotics, and the promotion of research and education into antibiotic alternatives.